Hello, and thank you for joining me. Today, I am going to provide you with a brief overview of the ICD10CM Codebook, Chapter 6 Coding Guidelines that review the diseases of the nervous system. Again, this is a brief overview. It is very important that you go through and read all of the guidelines thoroughly. Chapter 6, Diseases of the Nervous System, reviews all codes pertaining to the G category, so G00 to G99. Now, the first guideline is very important because it surrounds default codes, and that is regarding dominant versus non-dominant side. So these are codes that fall in category G81. For example, if we have hemiparesis, hemiplegia, monoparesis, monoplegia, these are the types of conditions that pertain to dominant versus non-dominant side. The way it breaks down is by ambidextrous, left side, right side. So there are many times that our providers do not provide us with the documentation specifically saying that the patient is right side non-dominant or left side dominant. Therefore, if we only have the laterality specified as right or left, we have to go fall on the defaults of the guidelines, whether or not it's going to be coded to a non-dominant versus a dominant side. For ambidextrous patients, the default should be dominant. If the left side is affected and it's not specified as being the dominant side, we will default to the non-dominant side. Sorry about that. Now, if the right side is affected and it's not specified as being the non-dominant, your default will be dominant. So if you're right-handed, well, there are many right-handed people out there, like I'm right-handed. Well, that's my dominant side, is my right side. So for ICD-10 coding guidelines, they think of right side as being dominant all the time too. So that is why that is the default. So there's no unspecified code here for dominance. It's left side. If it's not specified as being dominant, it automatically is going to code to non-dominant. Right side, if it's affected and not specified as being non-dominant, it's going to code to dominant. Our second guideline falls in category G89, and this is referencing pain. So codes in category G89, pain not elsewhere classified. This code section may be used in conjunction with codes from other categories and chapters to provide more detail about acute and chronic pain or neoplasm-related pain, unless otherwise indicated below. So if the pain is not specified as acute or chronic, post-thoracotomy, post-procedural, or neoplasm-related, do not assign codes from category G89. So a G89 code should not be assigned if the underlying definitive diagnosis is known. For example, if our pain is due to our arthritis, we know that it's, due to that definitive diagnosis. For category G89, codes as principal or first listed. So it's acceptable to code a diagnosis code from category G89 when the pain control or pain management is the reason for the admission, such as for a patient with displaced intervertebral disc, nerve impingement, or severe back pain presents for injection of a steroid into the spinal canal. The underlying cause of the pain should be reported as an additional diagnosis. So when a patient is admitted for the insertion of a neurostimulator for pain control, we want to assign the appropriate pain code as the principal or first listed. When an admission or encounter is for procedure aimed at treating the underlying condition and a neurostimulator is inserted for pain control during the same admission, a code for the underlying condition should be assigned as the principal, and then the appropriate pain code would be used as a secondary diagnosis code. Subsection B is for use of category G89 codes in conjunction with site-specific pain codes. So codes from category G89 can be used in conjunction with codes that identify the site of the pain. So this includes all the codes from Chapter 18. So if the category G89 provides additional information, for example, if the code describes the site of the pain but does not fully describe whether the pain is acute or chronic, then both codes should be assigned. So for the sequencing, here we have two different guidelines. So if the encounter is for pain control or pain management, we want to assign the category G89 followed by the identifying code for the specific site of pain. If the encounter is for any other reason except pain control or pain management, and a related definitive diagnosis has not been established by the provider, assign the code for the specific site of the pain, followed by the code from category G89. When it comes to post-operative pain, this is all dependent on our provider documentation. So again, provider's documentation should be used to guide the coding for post-op pain, as well as whether or not a code is reportable per the guidelines for reporting additional diagnoses as a secondary code. So the default for post-thoracotomy or other post-operative pain not specified as acute or chronic is the code for the acute form. Now, this guideline is key. Routine or expected postoperative pain immediately after surgery should not be coded, because we know after surgery, we're going to have some type of pain. So if it's routine or expected, we do not code it. When it's out of the ordinary and the patient is suffering from severe post-op pain, then that's when we code it. Postoperative pain not associated with a specific post-op complication is assigned to the appropriate post-op pain code in category G89. Post-op pain associated with a specific post-op complication, such as painful wire sutures, painful pins, is assigned to the appropriate codes found in Chapter 19. For example, if a patient has a fracture and has pain due to an internal fixation device, this code would come from Chapter 19. And then if it's appropriate, then we could assign an additional code from category G89 identifying the acute or chronic pain. Chronic pain is classified the G892. Now, there is no time frame for defining when pain becomes chronic. It's all based on your provider documentation. Neoplasm-related pain codes to G893, and this is also based on provider documentation, and it's pain that's associated as being related, associated, or due to cancer, primary or secondary malignancy, or a tumor. So this code is assigned regardless whether the pain is acute or chronic. It automatically goes to neoplasm related if it is due to that type of tumor or cancer. So the code can be assigned as principal or first listed when it is the reason for the encounter. The underlying neoplasm also needs to be reported as a secondary diagnosis code. When the reason for the admission or encounter is management of the neoplasm and the pain associated with the neoplasm is also documented, that's when we code that G893 as a secondary diagnosis. Now, the last section for Chapter 6 is regarding chronic pain syndrome. Now, there are 3 different codes here. So when it comes to chronic pain, we can also have central pain syndrome or chronic pain syndrome. It's different than that term, chronic pain. Central pain syndrome codes to G890. Chronic pain syndrome goes to G894. Again, this is different than chronic pain, so we're only going to use these codes when the provider specifically documents that condition. If they just document chronic pain, we code to chronic pain. But if it's specified as chronic pain syndrome, that makes a difference and we would code to G894. Or if it is documented as central pain syndrome, then we code to that diagnosis code. That is a brief review over the Chapter 6 coding guidelines for diseases of the nervous system. Thank you for joining me.